Hi, Wen.
Hello, Wayne. How are you?
Same.
Wen, would you like to introduce Álvaro? Would you do the honors? No sound? So I will do the honors then. And it's my great pleasure to introduce to all of you my dear friend, many years of friendship with Professor Álvaro Campero, who is the chairman of the Department of Neurosurgery at University of Tucumán in Argentina. Álvaro is a great surgeon, a great anatomist, as well as he's a great friend. And I know we are going to have a great time hearing his talk. Álvaro, thank you very much for accepting this invitation, for being with us today. My students are thrilled that you are here with us.
Okay, Carolina, thank you very much for the invitation. And Gwen, thank you very much. It is a big pleasure for me to be here. So, if could you watch the screen? Is it okay?
Yes, it is. It is okay.
Okay, let's go. Well, thank you again. And I'm going to talk about the microsurgical anatomy of the cerebelopontine angle, but with the surgical view. So I will try to show something in relation with the surgery. Again, thank you very much, Carolina and Gwen, and congratulations for this meeting. Our philosophy is from the laboratory to the operating room, and that is the power of the anatomy. So I will try to show our philosophy about that. It is very important to practice in the laboratory, maybe in a course, or if we have a laboratory in our department, it's better to go every day and so on. But especially in skull base, before to go to the patient, we have to practice different kind of approaches with the cadavers. So this is some pictures about courses that we give in different places of the world. So in relation with the cerebelopontine angle, this region is located between the upper and lower lips of the cerebelopontine fissure. So in this anatomical specimen, the upper and inferior limbs of the cerebelopontine fissure show where is the cerebelopontine angle region. And in this region, we have inside the region between the 5th to the 11th cranial nerves. So we can see here 5th, 6th, 7th, and 8th, 9, 10, and 11. And of course, sometimes in some cases with a tumor, for instance, sometimes the third and the fourth cranial nerve also can, in the margin of the cerebropontine region, we can see that nerves. And it is very important to talk about this, the three neurovascular complexes that Professor Rhoton described many years ago. We have three neurovascular complexes. And thank you, Professor Rhoton, because this idea. So we have the upper complex, and it's mainly the fifth cranial nerve and the superior cerebellar artery. The middle complex, that is from the ICA and also the 7 and 8 cranial nerve, and the lower complex, that is the pica and also the lower cranial nerve, 9, 10, and 11. So I will try to explain or to talk in this lecture thinking about these complexes. So I'm going to talk about the upper complex first, and we are discuss the trigeminal nerve and also the suprameatal tubercle, always thinking about the surgery. In relation with the trigeminal nerve, the most common pathology of the trigeminal nerve is the trigeminal neuralgia. So we have to remember that usually the conflict between the artery and the nerve is at the level of the transition zone of the myelinization of the nerve. So this is the central myelination and the peripheral myelination. So here, at the level of the Obersteiner-Redlich zone, is where we have to find the compression. So usually, of course, we can have a compression here at the level of more distal, but usually we have to find at this level. So we can see in this video, in the right side, in the semi-sitting position, a compression between the inferior cerebellar artery and the entry zone of the nerve. In this case, we have in the right side, in the semi-sitting position, the superior cerebellar artery and the entry zone of the nerve. In this case, a little bit more lateral, but near the entry zone, we can see the superior cerebellar artery and the zone of the nerve. So usually we have to try to find this compression, this conflict at the level of the entry zone. And usually we try to displace the artery and then to put the Teflon. And in this case, we have another superior cerebellar artery damaging the nerve a little bit more distal than the entry zone. So we can see how the nerve have a conflict with the artery has a conflict with the nerve. So usually we use a retrosigmoid approach, but with the superolateral view. That is very important in our opinion. So we use this direction between the tentorial and petrosal portion of the cerebellum. So another important thing is the veins around the entry zone of the nerve. In this beautiful specimen, we can see a conflict from the superior cerebellar artery at the level of the entry zone, but also we have to preserve the superior petrosal vein in order to avoid some problems in the post-op. And we published this paper in 2022 about the bridging veins in relation with the trigeminal nerve, and we perform a classification with the retromeatal veins at the level of the meatus and also the premeatal veins. So in this case, in these veins, we have to preserve, we have to do our best in order to preserve that vein, the veins ahead to the internal auditory canal. So we can see a surgery in the left side, and we can see the vein, and of course it is easier to coagulate and cut, and it is not so comfortable to work in between the veins, but we have to try to cut the arachnoid to preserve all the branches of the vein at that level, and using very small windows put the Teflon in order to separate the artery from the nerve. So we can see how we can preserve the vein, and also we can do an effective surgery. This is the final view. So I would like to show a case. It is very important, the MRI. We use a T2 in the MRI, and also T1 with gadolinium. We can see conflict in the left side. So in this case, we are cutting the arachnoid, try to not to coagulate the vein, and we can see an inferior artery and how the nerve is dislocated a little bit between the artery, and putting the Teflon between the artery and the nerve. It is a very anatomical surgery, and we can see also the vein here, the artery separate by the nerve from, because the Teflon and the vein and so on. Another important thing to remember is the suprameatal tubercle. The suprameatal tubercle is a small piece of bone above the meatus. Sometimes it is flat, but sometimes it's very prominent. So in this picture, we can see the suprameatal tubercle above the 7 and 8 cranial nerve. So sometimes, for instance, in anterior petrosal meningioma, we have to drill this bone in order to have a better visualization of the pathology. So in this anatomical picture of the right CP angle in a semi-sitting position, an anatomical view, we can see the vein, the suprameatal tubercle, 7 and 8 cranial nerve, the ICA, and the lower cranial nerve, and the vertebral artery, and this is the flocculus. So sometimes we have to drill this suprameatal tubercle in order to have a better visualization. I will show some cases. This is a very small anterior petrosal meningioma with the patient with the atypical trigeminal neuralgia. We can see the left fifth cranial nerve, but we cannot see in the right side because the nerve is displaced because the tumor. So in this case, in the semi-sitting position, retrosigmoid approach, in the right side, we are drilling the suprameatal tubercle in order to have a better visualization of the tumor and also of the trigeminal nerve. Inside the suprameatal tubercle, we don't have any that we can damage, so we can drill with very comfortable. Of course, we have to take care about the 7 and 8 cranial nerve. And after that, after the remotion of the tumor, we put the endoscope in order to see the freedom of the nerve. And we can see the pre and post-op MRI in the different sequence, and also the patient without trigeminal neuralgia after the surgery. Another case, a real petroclival meningioma, very small, because we can see the fifth cranial nerve and the petroclival meningioma medially to the fifth cranial nerve. Also a patient with the atypical trigeminal neuralgia. So we perform the same. We can see here the fifth cranial nerve, the meningioma medially to the nerve. This is the 7 and 8 cranial nerve, the Tübingen line, and we have a big suprameatal tubercle. So we are drilling the suprameatal tubercle in order to have a better visualization. After that, we are coagulating and cutting the attachment of the meningioma. Of course, we have to take care about the sixth cranial nerve. And finally, after the cutting of the attachment of the tumor, we are removing the tumor and giving freedom to the fifth cranial nerve. We can see now the fifth cranial nerve, the suprameatal tubercle that was already drilled, the vein, and the 7 and 8 cranial nerve. And we can compare the pre and post-op MRI in the different view and the patient after the surgery. And also, if you want to see the 3D videos, we published the last two cases in this journal. Another case, we operated 3 weeks ago, trigeminal neuralgia in the left side, but we can see a big suprameatal tubercle in the MRI. So in this case, we had to drill because in the trigeminal neuralgia, it is not so common to have to drill the suprameatal tubercle in the trigeminal neuralgia, but sometimes we have to be prepared to do that because we don't have a good visualization of the nerve. So, and we have also to take care about the petrosal vein, not to damage with the drill, and also the 7 and 8 cranial nerve. And we can see after the drilling, and this is before and after the drilling in order to compare. And then in this case, we have two compression, one above from the superior cerebral artery, another in the inferior portion of the nerve. We are separating this is the ICA and putting the Teflon in order to avoid the compression. This is the final view, and usually sometimes when we don't have too much arachnoid, we use fibrin glue in order to fix the Teflon. Let's go to the middle complex. In the middle complex, we have many important anatomical things. The facial nerve, the internal auditory canal, the ICA, and also the horizontal fissure. So we are going to separate this issue. In relation with the facial nerve, the most common pathology is the hemifacial spasm. After the trigeminal neuralgia is the second most common neurovascular conflict. The same like in the trigeminal neuralgia, we have to see and to look the compression at the level of the transitional zone of the 7 cranial nerve. So this is the exit zone of the 7 cranial nerve. But the problem in this picture we can see, in this anatomical picture, this is the 7, the intermedius, the 8 flocculus, the foramen of Luschka, choroid plexus, and the lower cranial nerve. The problem is we go from lateral to medially, lateral to the exit zone of the facial nerve, we have the 8th cranial nerve and also the flocculus. So that means that we have to try to find this portion of the facial nerve from below to above. So we try to recognize the lower cranial nerve, mainly the 9th cranial nerve, and go from the 9th cranial nerve to the exit zone of the facial nerve. So in these surgical pictures, look, this is the 7 and 8 cranial nerve. We never go to the 7 and 8 cranial nerve. We find the lower cranial nerves, cut the arachnoid, follow the 9th cranial nerve in order to find the exit zone of the facial nerve. So this is the flocculus, this is the 8th, and in front the facial nerve, but we cut this arachnoid between the flocculus and the 9th cranial nerve. This is choroid plexus. Look that we are working from below to up. We dissect the arachnoid at the level of the 9th cranial nerve. And now we have a good visualization. This is the vertebral artery, and this is the artery that are damaging the facial nerve. This is the 8th cranial nerve, and this is the facial nerve. We mobilize the artery, and we can see now the exit zone of the facial nerve. We try to have this visualization. And at the end, we put the Teflon and the artery is below, not below, posterior to the Teflon. So we use in this situation from the hemifacial spasm a retrosigmoid approach, but with the inferolateral view, like in this picture, completely different like in the trigeminal neuralgia. One case, very hard hemifacial spasm, like you can see in the left side, we can see the conflict here with the artery at the level of the exit zone. So in the left side, in the semi-sitting position, we have vertebral artery, but this is the artery that are touching the facial nerve, and we are putting the Teflon between that artery and the facial nerve at the level of the entry zone. We have to have this view, and we have to put in a good position the Teflon in order to separate the artery from the nerve, and we can see the pre-op and the post-op with the complete release of the spasm. Another case, a lady with a heart spasm in the right side. In this case, we can see in the MRI the artery a little bit more distal than the exit zone, and we can see also in the T1 with the gadolinium. And during the surgery, we are working from below to up. This is the lower cranial nerve, the choroid plexus, and we are cutting the arachnoid, following the ninth cranial nerve. And we can see this is the facial nerve, and this is the artery that are touching and damaging the facial nerve. This is the 8th and the 5th at this level. We have, of course, to try to preserve any small artery, and sometimes we use that artery in order to fix a little bit the Teflon, and this is the final view, and finally putting the fibrin glue in order to fix the Teflon. And we can see the post-op MRI immediately after the surgery with the complete release of the spasm. Let's go to the internal auditory canal. And when we think in the internal auditory canal, we think in vestibular schwannomas. And if we are going to operate a vestibular schwannoma, it is difficult to think to operate in this situation. So we can see just the proximal control or visualization of the nerve 7 and 8, but we cannot see the distal portion of the nerve. So we have to drill the posterior wall of the internal auditory canal in order to find the nerves, especially in big tumor, the facial, and in a small tumor, also the cochlear nerve, in order to try to preserve anatomically and functionally, and also to remove that part of the tumor inside the internal auditory canal. And why? Because in a normal situation or in a pathological situation, always the facial nerve is ahead and superior, and the cochlear nerve is ahead and inferior. So we can see in this bone specimen, this is the horizontal crest, and upper and anterior is the facial nerve, anterior and inferior the cochlear nerve, and posterior and superior the superior vestibular nerve, and posterior and inferior the inferior vestibular nerve. This situation is the same with tumor inside the internal auditory meatus. So in this dissection, we can see in the right side, we can see facial nerve, cochlear nerve, superior vestibular, inferior vestibular, and also the ICA artery. So I would like to show one case, a small, just intra-meatus tumor in the left side. So at the beginning, we can see the 8th cranial nerve, the superior vestibular, the inferior vestibular that start or grow the tumor, the tubing line, after the drilling of the posterior wall of the meatus. We can see the superior vestibular nerve, the tumor, and then we are removing and dissecting the tumor, and we can see now this is the superior vestibular nerve, the facial nerve, anterior and superior. And after the resection, we can see the inferior vestibular nerve we cut because the tumor grow from the inferior vestibular nerve, the superior vestibular nerve preserved, the facial nerve anterior and superior, and we are mobilizing a little bit superior all the 7 and 8, and this is the cochlear nerve. Facial nerve anterior and superior, cochlear nerve anterior and inferior. What is the tubing line? We described this line with Carolina, Dr. Tatajiva, and also Professor Rhoton. And if we see the dura of the posterior portion of the petrous bone, we can see some lines that disappear at the level of the inferior portion of the meatus. And this disappearing of these lines is like we can see like or imagine like a line, and we can see in a surgical view this is the tubing line. So we know at the level of the tubing line that is the floor of the meatus. So if we cannot see where is the meatus because we have a tumor, with this tubing line we know where is to start our drilling. And we published many years ago, and I would like to show some cases. This is a small vestibular schwannoma, and we can see this is the tubing line at this level. So we use the tubing line in order to know where is to start our drilling. In not so big tumor, vestibular schwannoma, we first drill the posterior wall of the meatus and then go to the tumor. So after removing the tumor inside the meatus, we go to the CP angle. We are performing the bulking with the ultrasonic aspiration in order to can perform the arachnoid dissection in a semi-sitting position. It's a little bit easier because we all the time have the operative field totally clean because the water, we are dissecting the facial nerve. The patient hasn't audition, so we are taking care about the facial nerve. Of course, we try to preserve also the cochlear nerve. And we are removing the last portion of the tumor at the level of the meatus, and this is the final view of the facial nerve and all the anatomy of the CP angle. Fourth cranial nerve, superior cerebellar artery, fifth cranial nerve, lateral portion of the pons, seventh cranial nerve, sixth cranial nerve, and the lower cranial nerves at the inferior portion of the CP angle. And we can see the pre and post-op MRI in the different view, and also the patient after the surgery. Another case, sometimes this is a meningioma, not a schwannoma, but sometimes we have to drill the internal auditory canal also in meningiomas, especially if the meningioma grow inside the meatus. So we can see also the T2, and in the left side, semi-sitting position, this is the meningioma, a little bit blood meningioma, but we are working below the tentorium. This is the fourth cranial nerve and superior cerebellar artery. We are separating. This is the 7 and 8 cranial nerve, and the tumor medially to the 7 and 8 cranial nerve. We are performing the debulking and so on. We can start to see the fifth cranial nerve. The patient had atypical trigeminal neuralgia. Now we are drilling the suprameatal tubercle in order to have a better visualization of the petrous apex in order to remove that portion of the tumor. So we have to use in skull base the drill. It is very important to use for have better results. This is the fifth nerve. And now we are drilling the internal auditory canal like in a vestibular schwannoma in order to remove the portion of the tumor that go inside to the internal auditory canal. So sometimes in some meningiomas, we also have to drill the meatus. And this is the final portion of the tumor, very small. And this is the final view with the drilling of the internal auditory canal. And we can see the pre and post-op. We remove the tumor inside the internal auditory canal and a little bit above, and also the T2, and the patient after the surgery. Let's go to talk about the anterior inferior cerebellar artery. So we have to remember that usually the tumor, the vestibular schwannoma, is irrigated by the branches of the ICA. Of course, the tumor also has some kind of irrigation from dural arteries, but the main irrigation of the vestibular schwannoma is the ICA. So this is a case that I operated 2 weeks ago, a small tumor. I would like to show how the artery irrigate. We are performing the debulking with the ultrasonic aspiration, and then we try to work in the upper portion of the tumor to separate from the trigeminal nerve, and then we go, but after the debulking, we go to the inferior portion of the tumor in order to separate from the lower cranial nerve, and also to coagulate the branches of the ICA in order to devascularize the tumor. Sometimes, especially in the tumor with big vascularization, we perform that. And then, like in the other cases, we use the arachnoid membrane in order to dissect. Then we recognize and cut the dura at the level of the Tübingen line, and then drill the internal auditory canal, the posterior wall. We start with the 4 millimeters burr diamond, and then 4, 3, 2, and we finish with 1 millimeter. And then we work from the at the level of the proximal or distal. It depends if the dissection is easier from the meatus or from the brainstem. Usually we perform both from one and the other. We can see here, this is the facial nerve and this is the cochlear nerve. And we are removing the tumor at the level of the internal auditory canal, the final portion of the tumor. This is 7 and this is cochlear. We can see the vein that we have to preserve, the 5th cranial nerve, and below the 7th cranial nerve, and the lower cranial nerve 9, 10, and 11 with the arachnoid, and the final view with the 6th cranial nerve and lateral view of the pons. And I don't have the post-op MRI because I operated just 3 weeks ago, but this is the patient after the surgery. Another case, this is a very interesting case. A colleague, plastic surgeon with this tumor that was operated before by another team, but this is the pre-op MRI and this is the post-op MRI because the other team just can take a biopsy because very bleeding tumor. So then the patient was sent to gamma knife, increased the edema, hydrocephalus, BP shunt, and so on. So we receive the patient in this condition with a big tumor, with big edema, and so on. And this is a very vascularized tumor. We perform an angiography, but it was difficult to perform an pre-op embolization because the risk of the embolization of the facial nerve. So this is during the surgery. So the first thing that we perform is go to separate the lower cranial nerves and then go and recognize, like in a angioblastoma or like in a AVM, we recognize the branch of the ICA that go to the tumor and coagulate and cut. So this is very useful in the very vascularized tumor. And after that, we perform the surgery like in a normal tumor. You can see that we don't have a big bleeding, but that was because first we went to the artery and to coagulate not the ICA, just the branch of the ICA that go to the tumor. And this is the final view, very, very thin facial nerve, but with the anatomical and functional preservation. And we can see the pre and post-op MRI in the different view, and the patient 2 months after the surgery, he come back to his practice. Another important thing is to remember that sometimes the ICA can be inside the bone. This is a very uncommon situation, but could happen. And I would like to show a case. This is a very beautiful tumor to operate because with a CSF lateral to the tumor at the level of the meatus, a small tumor, and so on. But when we separate and reclean the cerebellum, we can see that the ICA is inside the bone. So we have, please, not to cut the dura here, but because we can damage the artery, we have to drill around the artery and mobilize the artery with the dura. So this is the video in the right side in the semi-sitting position. So we are cutting the dura, but in order to drill and to mobilize the artery with the dura, we can see here. Because if we don't drill, we can damage the artery. After that, we mobilize the loop of the artery with the dura below, and then we work like normally in the tumor with the bulking and so on. This is the tumor, the artery is below, and at the final step of the surgery, we remove, and this is the 7 and 8 cranial nerve, and then we put again in the position, in the normal position, the artery. And we can see the pre and post-op MRI and the patient after the surgery. Finally, in relation with the middle complex, I would like to talk about the horizontal fissure. What is the horizontal fissure? Is between the superior and inferior semilunar lobulus of the cerebellum, and then goes above the flocculus and go straight to the middle cerebral peduncle. So in some lesion inside the pons, we use a retrosigmoid approach, trans-horizontal fissure, in order to open at the level of the middle cerebral peduncle and go inside the pons. And I would like to show this case, a Pontin's cavernoma in a young lady with the bleeding. So in this case, we use opening the horizontal fissure, open at the level of the middle cerebral peduncle in order to remove the cavernoma. In this situation, in a retrosigmoid approach, we can see the different view. So this is the good publication about this approach. So in the retrosigmoid approach, right side, first we cut the cerebellum medular cister in order to relax the cerebellum. This is right and medial, lateral. We are right side. We are cutting the arachnoid at the level of the horizontal fissure in order to go to the middle cerebral peduncle. We have to cut the arachnoid and to open the fissure like in a Sylvian fissure, like when we open the Sylvian fissure. And this is the middle cerebral peduncle. We have to cut very well the arachnoid in order to have a good visualization and of course to preserve all the veins. Now we are with the dissector opening at the level of the middle cerebral peduncle in order to go to the cavernoma, a big cavernoma at the level of the pons. And we can see the hemosiderin. And after that, we have to perform the dissection. Of course, it is very important in all that kind of surgeries, the neurophysiological monitoring in order to know if the thing that we are doing with our instrument, it is okay or not for the patient. Now we can see with the good magnification, we have a good view of the cavernoma, and now we perform the dissection, the 360 dissection, and the remotion of the cavernoma. We also watch that we don't have any piece of cavernoma, and finally we use some kind of hemostatic in order to avoid the bleeding. This is the final view through the horizontal fissure. And we can see the pre and post-op MRI in the T2, also in the FLAIR, and in the sagittal view. And this is the patient after 3 weeks of the surgery with a very good recovery. Let's go finally to the lower complex. And in the lower complex, I would like to talk a little bit about the jugular foramen and also the lower cranial nerves. The jugular foramen, this very important foramen in the skull base, is divided into 3 compartments. The posterior compartment or posterolateral compartment, the sigmoid compartment, where the sigmoid sinus go. In the middle, the intrajugular compartment or nerves compartment, where the 9, 10, and 11 cranial nerves go. And in the anteromedial portion of the jugular foramen, we have the petrosal compartment, where the inferior petrosal sinus goes through. So in this specimen, we can see the anterior portion from the inferior petrosal sinus, the posterior portion from the sigmoid sinus, and the intermediate in the middle compartment where the 9, 10, and 11 cranial nerves cross the foramen. And it is important to realize that the 9 cranial nerve go through alone, and the 10 and 11 go in the same foramen. So 9 alone and 10 and 11 go together. I would like to show some cases in relation with the lower cranial nerve. This is the patient with the glossopharyngeal neuralgia. So we can see in the left side, not so common like trigeminal neuralgia or facial spasm, but we can see the 9 and the 10 and the 11 here. And this is an artery that are damaging the nerve. So we have to take care with the dissection and then put the Teflon between, like in the trigeminal neuralgia or in the hemifacial spasm, we put the Teflon between the artery and the nerves. Another case, lower cranial nerve schwannoma, not so common like vestibular schwannoma. We can see the opening of the jugular foramen and also tumor outside the jugular foramen, some a little bit cystic. So we perform a similar approach like in a vestibular schwannoma, the retrosigmoid approach. In a semi-sitting position, we are performing the debulking with the ultrasonic aspiration, and the goal here is to try to preserve the lower cranial nerves. So here, to preserve the facial and the cochlear nerve is easy, but the difficult is to try to preserve the lower cranial nerve because are very straight because the tumor. And this is the final view, the trigeminal nerve, facial nerve, cochlear nerve, facial nerve, and the lower cranial nerve here at the inferior portion of the CP angle. And we can see the pre and post-op MRI in the different portion of the sepal angle and different view of the MRI, and also the patient that was operated during the pandemic. This is the patient after the surgery with the good function and also with the good function of the lower cranial nerve, that it is very important. Another case, jugular tubercle meningioma. We can see jugular tubercle meningioma. So in this case, we perform a midline approach, midline suboccipital approach. This is the tumor mobilizing up the tonsil and the cerebellum. We are performing the bulking of the tumor, separating from the spinal cord and the medulla, cutting the arachnoid. We can see a branch of the V4 segment of the vertebral artery going to the tumor. We have to coagulate and cut, and this is the 12th cranial nerve. And the last portion of the tumor, it is very important to try to preserve the lower cranial nerve in order to avoid the damage of the deglutition of the patient. This is the lower cranial nerve and the last portion of the tumor, and we are cutting, and we can see in a good situation the lower cranial nerves going to the jugular foramen. This is the 7 and 8 cranial nerve. And we can see the pre and post-op MRI in the different view and the patient after the surgery. The last cases, a case of the choroid plexus papilloma. We can see very characteristic MRI going through the foramen of Luschka in the T2. We usually, in this kind of tumor, use an MRI, an angiography in order to know the irrigation of the tumor. And we can see the very characteristic aspect of the tumor. We have to recognize the branches of the cerebral artery, in this case, the superior cerebral artery that go to the tumor in order to separate and to load the vascularization. And this is the very important thing, to try to preserve anatomical and functionally the lower cranial nerve. This is our main goal. Now we are using the ultrasonic aspiration. We can see here the ICA, and we have to recognize the very small branches that go to the tumor, but not the main artery. We have to preserve the main artery just to coagulate and cut the small branches that go to the tumor. And this is the final view after the remotion. This is the foramen of Luschka. We can see the fourth ventricle because it is bigger because the tumor, and this is 7 and 8, 6, and the lower cranial nerve with the good preservation. And pre and post-op MRI with the complete resection of the tumor and the patient after the surgery. And finally, sometimes we have tumors that are in relation with the 3 complexes. And one kind of this tumor are the epidermoid tumor. We can see a patient with a young lady with this epidermoid tumor with the atypical trigeminal neuralgia. We can see in the upper portion of the tumor, in the diffusion, in order to recognize the epidermoid cyst. And now we are working, this is the last case, we are working in the different corridor of the sepal angle, upper to the 5th cranial nerve, lower to the 5th cranial nerve, upper to the 7 and 8, lower to the 7 and 8. But the important thing is to preserve all the cranial nerves and of course the vascular structure. This is the 3rd, this is the 6th, and sometimes we use the endoscope in order to realize that we remove all the tumor. And we can see how in the post-op MRI the anatomy goes to the normally in the upper portion also, and the diffusion without a tumor, and the patient after the surgery. So I would like to introduce this. This is the Neurosurgical guide. It's a free platform where you have videos about the anatomy, the surgical approaches and also the surgical cases. It's completely free. You just have to put your name and so on. Then you can use this platform. It's in Spanish and also in English, and the name is Guía Neuroquirúrgica or Neurosurgical Guide. Again, thank you very much, Carolina and Gwen, for the invitation, and thank you very much for the audience.
Thank you, Alvaro. This is a great start for us coming down from the supratentorial to the infratentorial compartment. I think I lost my audio. Can you hear me still?
Yes, perfect.
Okay. And that's a great talk. Thank you so much for that. I guess we have over 120 people present, and several greetings for you from South America and also Central America and Asia. So everybody's thanking you. And I think we have time for questions. If anyone wants to type your question down at the chat space, we may have time for one or two questions. We also, if we don't have time for all the questioning, Alvaro, if you would, I know you gave us your contact, but if you may type your email and someone wants to reach out and reach out to take questions from you directly, that would be helpful as well. Thank you so much. Everybody's thanking you. And when
Done.
would you like to make comments or put?
Well, can you hear me?
Yes.
Okay, I switched my mic this time. You can hear me. Thank you. Alvaro, that was once again, congratulations. He's an outstanding surgeon. You know, you don't have to listen to me telling this. Just watch, you know, his lecture, his surgery is superb. Outstanding neurosurgeons. I just want to congratulate you. I've seen his lecture before in Chapecó in Santa Catarina and was amazed. Actually, he's good not only his tumor, he's good in almost every aspect of micro neurosurgery. So you know, that's not fair because Argentina, they are world champion in soccer, and now they're doing outstanding job also in neurosurgery, surpassing most of the countries. So congratulations once again, Alvaro.
Thank you very much, Gwen. Thank you very much.
I think we have also thanks and praises for you, Alvaro, from Dr. Salman Sharif. Thanks, Professor Sharif, for being with us. The big man for the World Federation is here with us today and saying thank you. Alvaro, just for the young guys that are starting and trying to follow you over, you have showed that one approach, the retrosigmoid, we can do most things in the CPA and go through that approach, but we can customize the approach by going by different routes, right? And you showed that as well very well. And you showed how you position your spatula, your brain spatula. Do you have any preferences on the sizes, the tapering edges of the spatulas that you use for each route?
Yes, it's a good question. For instance, for trigeminal neuralgia and hemifacial spasm, I use a very small spatula. You know, now there are many people that discuss that we don't have to use spatulas. We have to use just with the aspiration and so on. But for instance, in neurovascular compression, I would like to have my left hand with the aspiration free in order to mobilize, because if you are mobilizing the cerebellum, you don't have completely freedom in order to use. So I like to use spatula after the remotion of the leak CSF with the cerebellum is relaxed. In trigeminal neuralgia and in hemifacial spasm, I use a very small spatula. The difference is, for instance, if you operate a big vestibular schwannoma or a big meningioma, petroclavian meningioma, or so on. I use a big spatula in order to try to separate all the cerebellum and to have a good view from up to below. So it depends the case. Sometimes we don't use spatula, but I don't think, of course, there are many surgeons that say that, yes, but I don't think that after the release the CSF, that if you put the spatula just to to keep the cerebellum, in this case, or the brain in the pterional approach, for instance, that you do some damage. But should be after a good relaxation of the cerebellum after you evacuate CSF.
Wonderful. Thank you so much for that. I don't see any other questions. I only see praises for you, my friend. Well do, praises for you.
Is
And
there,
I
can I ask a question?
sure.
What kind of microscope do you use? Because for a semi-sitting position, if you have a very huge optic head from the microscope, it's very difficult for you to, is the distance between the surgical field and the surgeon is very large. So it's very tiring. So any recommendation for any
Yes.
special
Yes,
microscope?
it is a very good point. Unfortunately, the new microscope are not developed from the semi-sitting position, in my opinion, especially for the left hand, because you have the microscope, the branch of the not the branch, the arm of the microscope, and then the microscope. So in the left side, it is difficult sometimes to put. What we do at the beginning, because for instance, if you operate a big vestibular schwannoma, you cannot operate in the air. You have to rest your forearm. At the beginning, we use the table. We put like a cushion in the table, but we don't have independence. So we perform a Davis, so that is like I don't know how to explain in English, but it is separate from the table. So we put up or down. So we put the microscope very close to the head, and I don't have below nothing to, so I can put my hands free. But we have to, for instance, if this is the head of the patient, we don't have nothing below. So we can put very close the microscope with the head of the patient. So for instance, sometimes inside the CP angle, I use 20 millimeters or lesser than 20 millimeters. But it is important to not have anything below, because if you have something in relation with the table, we cannot put your hands.
There's a kind of armrest.
That's right.
Professor Yashargil, it's like a T-shaped, so you can rest your arm. Actually, I don't use it, but many people they use it. It's a kind of.
Let me see just a little bit, if I can. Let's go to talk if you want. I will try to show something. Okay, so can I share a little bit?
You
Let's
do.
see. This is the Davis. Okay, so I operate like this. So this is independent from the table. Okay, so we can put down if I need, and I operate like this. So this is, I put this is sterile, and I work in this situation. So it is very easy. We cannot buy this. You have to develop this.
Thank you, Álvaro, for that. I think we do have time for one more question, and that came from Dr. Sanchez. He's asking about the drilling of the suprameatal tubercle. what are the challenges that you find during this step that you would warn young neurosurgeons?
Perfect. Inside the tubercle, we don't have anything that we can damage. So in this way, we can drill comfortably. But we have to take care above the petrosal vein, because usually the petrosal vein is 3 or 4 millimeters from the tubercle and below the 7 and 8 cranial nerve. So it's similar like when you drill the optic roof or the clinoid, the anteroclinoid process. You need a lot of irrigation in order to avoid the heating of the burr. But so above petrosal vein, inferior the 7 and 8 cranial nerve. No more.
Great, Alvaro. And I think it's just what we have time for. I ask my excuses for Dr. Paulo and Dr. Nicholas, and I encourage you to reach directly to Dr. Campero for the questions that you have mentioned. Thanks, Alvaro, again for a great start for our intratentorial excursion during the next month. All the way till August, we will be working on the intratentorial space. Thanks, Wayne, for putting all this together. Thanks, everyone who is present. And I would like to remind everyone that every last Friday of the month, we get together to discuss the anatomy that makes our surgery safer in the World Federation Rhoton Anatomy Day. Thank you all very much. Thanks, Alvaro. Good to see you, guys.
Thank
Thank
you,
you very
Alvaro.
much.
Thank you,
Thanks, Wayne.
Carolina. Thank you,
Bye,
Imad.
guys.
Thank you.
Thank you very much.
Bye-bye.
Bye-bye.
Bye-bye.